Welcome to Menopause Made Easy Part 5. This video, I'll be highlighting the risk of hormone replacement therapy or HRT. Venous thrombotic events occurs when you have blood clots in the deep veins in the legs, and they can travel to the circulation and lodge themselves in the lungs as pulmonary embolisms. Endometrial cancer, breast cancer, ovarian cancer, effects of HRT on the risk of DVT. There's obvious increased risk. And if you had a previous VTE before, if you go on HRT, the incidence of VTE is 10.7% versus 2.3% if you're on placebo. So there's a 5-fold increase risk. HRT and DVT, oral estrogen replacement therapy increases the risk of VTE. The incidence is high in the first year of treatment. It is not dose related. No difference between opposed and unopposed estrogen. So there's no difference between estrogen only or estrogen and progesterone combined. Patients who have a history of VTE, there's an increased risk of VTE with oral estrogen, and very high risk patients of developing DVT are more liable to develop DVT when using HRT. So the evidence is conclusive. HRT and endometrial cancer, if you're not on HRT, the relative risk is 1.0. If you're on estrogen only, it's 5 times increase risk. And to normalize things, if you add a progesterone to protect your endometrium, the risk comes back to 0.9 or 1, around there. Non-users of HRT have an odds ratio of 1.6 in developing endometrial cancer. Unopposed estrogen use, more than 3 years, 4.12. But if you add a progesterone, the risk normalizes back to 1.49. HRT and breast cancer. Short-term estrogen use, less than 5 years, is not associated with increased risk of breast cancer. Long-term use, however, more than 5 years, is associated with increased risk of breast cancer. I'm not sure whether HRT causes breast cancer or it just causes existing breast cancer to grow faster, and thereby you detect it more faster or more likely to detect it. The overall risk was similar when estrogen plus progesterone was used. Women receiving combined estrogen and progesterone regimen have greater risk of breast cancer than women using estrogen alone in this study. In the 1995 larger study, Nurses' Health Study, they concluded that breast cancer incidence did not differ significantly for users from that of non-users of HRT. Contraindications to HRT, absolute contraindications, obviously active breast cancer, endometrial cancer, other estrogen-dependent tumors, acute thrombotic disorders, undiagnosed vaginal bleeding. Relative contraindications include history of breast cancer, history of endometrial cancer, liver disease, history of previous thrombotic disorders. Side effects related to the estrogen component includes breakthrough bleeding, breast tenderness, headache, nausea, edema or swelling, bloating. Related to progesterone includes breast tenderness, headaches, depression, bloating, PMS symptoms, libido changes, acne, seborrhea, scalp hair loss. So, on a balancing scale, the risk includes VTE, endometrial cancer, breast cancer, etc. The benefits, climacteric disorders, and osteoporotic prevention. Right. This is a chart depicting how would you go about managing the symptoms of menopause. I got this from the clinical guidelines from Malaysia, issued by the College of Obstetricians and Gynecologists of Malaysia. So the first question you ask yourself is, do they have symptoms of menopause? Sorry. And if no, then you ask them to have a healthy lifestyle and you reassess them yearly. Oh dear. No. And if they have symptoms of menopause, and so then you ask whether there are any contraindications to HRT. If yes, then you again look for alternative approaches to management, which I mentioned in earlier videos, and reassess them yearly. If they do not have any contraindications, you may consider them for hormone replacement therapy, and you ask and check whether they have had a hysterectomy. If they have not had a hysterectomy, the womb is still intact, you check for their menopause status. If they're early menopause, you can consider estrogen, progesterone therapy. If they are late menopause, do not start estrogen, progesterone therapy. You look for alternative approaches and you reassess them yearly. If they've had a hysterectomy, and again, you check for their menopause status. If it's early menopause, you prescribe or consider prescribing estrogen alone therapy. If it's late menopause, do not start estrogen therapy. You look for alternative approaches and reassess them yearly. And if the patient comes with increased risk of osteoporosis, with regards to osteoporosis, you ask, is the patient at risk of increased risk of osteoporosis? If no, then there's no need for hormone replacement therapy and reassess them yearly. If they are at an increased risk from your bone scans and family history and blood tests, then you ask whether they have contraindications to HRT. If no, you check for their menopause status. If it's early menopause, no hysterectomy, estrogen and progesterone therapy combined. If they've had a hysterectomy, estrogen therapy alone. Menopause status, if it's late menopause, and again, you can, instead of instigating HRT treatment, you can consider bisphosphonates, aloxifene, or alternative approaches to management and reassess them yearly. So thank you for listening. In the next video, I will be sharing with you the Women's Health Initiative study, which changed the way doctors manage menopausal women with HRT.